Tonight's learning objectives include developing an understanding of metabolic therapies in the treatment of mental illness, evaluating qualitative measures of intervention outcomes and impacts on symptoms, giving examples of qualitative effects of ketogenic therapy on quality of life, and considering access to standard of care as an influence on ketogenic therapy adoption. I am very pleased this evening to be joined by Nicole Laurent, who is a practicing mental health provider who is the founder of the Brain Fog Recovery Source and who has published several papers on the impacts of metabolic therapy on mental health disorders, including bipolar disorder and schizophrenia. Nicole, welcome.
Thank you for having me. I'm really glad to be here.
We're so thrilled you're with us. Can you give us, to start out with, a little bit of background on how you got involved with metabolic therapies and ketogenic therapy specifically?
Sure. So I am a licensed mental health counselor in Washington State. And I was suffering, I have been for over 18 years now. And about probably 10 years ago or so, I was suffering from a neurological condition. And I learned about a ketogenic diet by accident, listening to podcasts and such. And I managed to implement a ketogenic diet by myself on my own. And I immediately noticed huge benefits and in terms of my condition. And what I really noticed and paid attention to as a psychotherapist was the profound effect that the ketogenic diet seemed to have on my mood. I would not have characterized myself as anxious in any way or having trouble regulating my mood. As a psychotherapist, I had lots of skills, DBT, CBT, did EMDR as a therapist, to regulate mood, but I did not realize how hard I had to work to regulate my mood, how often I needed to bring those skills in to just simply deal with life, right? And to feel okay. And when I did the ketogenic diet, there was such a profound mood shift that I found that it really didn't take any effort. I was no longer overwhelmed by small things, right? Mm-hmm. I always tell people you're not overwhelmed by unloading the dishwasher anymore. It's not too much, right? Or doing laundry or taking that phone call. The day just kind of unfolded well. And I thought, oh my goodness, my people that I work with who have been suffering with treatment-resistant mood disorders really need to know about this and need to learn about this. And that's really how I, as a clinician, started to move into this space and really wanting metabolic therapies to become accessible to people who could benefit from them.
Well, thank you for coming tonight and talking about some of the work that you've done. You have some slides that you prepared. So by all means, if you'd like to just dive right in, we should be ready.
Absolutely.
For those of you who are here with us live, please feel free to put your questions into the Q&A. I'll be monitoring that as Nicole is speaking, and I will be able to get those questions to her as they come in. So take it away, Nicole.
Thank you. So that my slides are primarily about a case series that I published in Frontiers in Nutrition for schizoaffective disorder. There's 2 individuals who had just a spectacular recovery using ketogenic metabolic therapy who I worked with that I just felt really compelled to publish. I actually have other case studies for different disorders in the peer-reviewed literature that I've worked to publish over the years that you're welcome to look at. But today we're just going to kind of focus in on these ones. And so we're going to look at this. I think that people have a lot of questions about what does this treatment look like and how does it work and how often do they have to be seen and what is the food they eat and what are the supplements. And So I think that going through a case series is actually very helpful in giving clinicians and even families an idea of kind of what does this look like in actual practice in the real world. So when we talk about schizoaffective disorder, so it's considered a serious mental illness, and it has not only really profound mood disturbances, but there's an element of psychosis that is a piece of it. And of course, with all serious mental illness populations, this looks a little bit different for everyone. There is not this, clean presentation in schizoaffective disorder. Some people have more negative symptoms, some people have less. But current standard of care really relies on medication interventions. And yes, psychotherapy is a component and a recommended component of treatment for this disorder. But generally, psychopharmacology is the main treatment. And so that would be great, except that there's really significant negative side effects for these individuals on these medications. And these include weight gain, and we're not just talking about, 10 or 15 pounds. We're talking about sometimes 70 pounds. Diabetes, disruptions in lipids, cardiovascular disease long-term. So the use of medications in this disorder, while it can keep symptoms controlled or at bay, has a real cost to this population, not only in their quality of life in the current moment as they're taking the medications, in terms of cognitive effects. They'll often complain about fatigue. They'll complain about problems thinking, problems focusing, problems feeling, but also in terms of their life expectancy, because these medications really do have significant metabolic effects long term. So these medications are not without cost for these individuals. But even before medications, it's important to kind of understand that in schizophrenia, now I'm going to refer to a very, very old study in which, everything was kind of called schizophrenia, but understand that it's in the same kind of constellation. But we've known that there has been problems with glucose metabolism in this population for decades now. And so this condition's been associated with poor metabolic health, insulin resistance, hyperglycemia, which just means poorly controlled blood sugar. And we see this in those not that are just on these medications, but even before medication is started. And so there's this broad connection between psychosis and metabolic dysfunction that's actually been understood for quite a while. So when we think about the connection between schizoaffective disorder and schizophrenia, we see areas of the brain, for example, that do not use glucose well for fuel. There's actually a term for it. It's called glucose hypometabolism. And so we see areas of the brain that do not use glucose efficiently for fuel. And in postmortem studies of individuals with schizophrenia, when they looked at the brain after death, they actually saw receptors for ketone bodies, an upregulation of receptors for ketone bodies, almost as though the brain was, or the assumption, the hypothesis is that perhaps the brain was trying to upregulate energy in a way that could rescue the brain. And so we definitely, this is not something that we're wondering about or we're confused about. We absolutely know that there is a metabolic dysfunction that is going on in the brain of individuals who have schizoaffective disorder or schizophrenia spectrum disorders. And so we really want to look at, what is a really powerful metabolic therapy? Well, it's the ketogenic diet. And what is a really powerful metabolic therapy for the brain? Well, the ketogenic diet, because it's been used in epilepsy for the purpose of changing brain metabolism for over 100 years. And so the first person, I always smile when I talk about my people that I publish on, because it's just a very rewarding work that I do when I get to talk about where they were and where they came from and how they got to where they are. So you'll hear smiles in my voice. Um, this person was a 17-year-old female. I was introduced to her by her dad. So her dad contacted me for private consultation, and he said she's not on board with this, but I'm making her come to the call, and she's willing to kind of hear you out. And when I met this person, she was having really severe suicidal ideation. She was having very severe symptoms. And she had been on medication for many years. So she'd actually been suffering from mood disorder and then finally a schizoaffective diagnosis for probably I think it was the last 3 or 4 years. But she'd actually been suffering from mood disorder for 6 years before we started KMT. And she said, I think I need to go to the hospital, and I said, well, good, go to the hospital because you need to be safe. And I said, you're kind of at a crossroads because what you're telling me is that the medications that you have been on are not working. She was highly medicated on the call. And for those of us that work with this population, you can see that they're having trouble to express themselves. They're having trouble being present. Their affect is very flat. And yet the suffering going on behind that is profound. And I said, you are at a crossroads because you're telling me that the medications that you're on are not working, and your parents are saying that that's the case as well. And you're going to go into hospital, and medications will be adjusted in such a way that hopefully they alleviate your symptoms and make you safe. But really, I think you kind of know. I think you kind of know where you're at with that. And I said that there's this other option that you can try when you get out of the hospital. If you decide that how your treatment is going currently is not working for you at some point, this path is always available to you. And I think that was a really important piece because it took the pressure away to make that decision in that moment about what treatment option she wanted to do. And sure enough, I got a call from her. I got a contact from her dad even before she had left the hospital asking to start ketogenic metabolic therapy. This person was very severe in her presentation. So I just kind of want to make that clear. Her parents had been sleeping outside of her door, taking turns, sleeping in the hallway, on the floor, outside her bedroom door, out of fear that they would lose her, that she would do some kind of suicidal act. This person used to ride horses, and could not ride horses anymore because she would get voices that to do things that were unsafe. This person learned how to drive but was not allowed to drive because her family was terrified. And there was always a parent with her at all times. She was pulled out of school. She was homeschooled. These are really important details because I think that some people think, oh, this is a dietary intervention. Maybe it helps people who don't have severe symptoms. That is not what we're seeing. And there was a profound stress on the family too, because this was not their only child. I believe there was several children in that family. And there was a lot of effort spent, understandably, trying to keep this person alive and keep this person safe.
Nicole, I just want to jump in here and say what you're describing is extremely familiar to those of us who work with children and families. This sort of desperate feeling that you have to sleep on the floor outside your child's bedroom in order to keep them safe, and that there is a really profound need for alternatives to this sort of group of medications that are routinely thrown at kids especially when they have the kind of metabolic side effects that they have. So I'm eager to hear this,
Mhm.
the rest of this case.
Yeah, absolutely. So many medications listed below. And this is someone who had always been in psychotherapy. Her parents made sure that that was an option. And so when I got her out of the hospital, um, I thought, I don't, I can't mess around here. I've got to put her on a nice good ratio. I got to make sure that she's making ketones and we increase the likelihood that she's going to potentially feel treatment effects. Because I know teenagers, I've had a few myself, and you don't have much time to convince them of things that might be good for them. So I put her on a fairly high ratio, a 2.5 to 1 ratio. And what that means, basically, for those who are not dietitian trained, is that there was 2.5 times more fat in her diet in grams com compared to protein and carbohydrate grams added together combined. And so her macros, this is what her macros looked like. Everybody should get personalized macros. Nobody wants to grab these macros and give them a go because everybody is different and they're based on certain things. And then after about 2 months, I brought her down to a 2 to 1 ratio. She was hungry for more protein, understandably, and we went ahead and we did that. And then really this whole ketogenic diet implementation for this person was really to prioritize ketone production above other things, anything else, and to just get her into a really good level of ketosis. And when these pictures I added in kind of last minute because I think that people think, oh, if you're going to do a ketogenic diet for mental health, you've got to do that 4 to 1 ratio. You've got to do that childhood epilepsy ratio of 4 to 1, four times the fat, compared to carbohydrate and protein combined. And at least for, I would say, the older kids, so this was a 17-year-old, basically an adult, right? Biologically speaking, that's not necessary for many. Um, Although maybe for younger children with psychiatric disorders, a higher ratio might be needed. I don't generally do macros for children, but this is examples of a 2 to 1 ratio, right? This looks delicious, does it not? So you've got these vegetables. There's lots of fat being absorbed in those vegetables. You have a nice, decent amount of protein. And sometimes you have a lovely fatty sauce or something like that. That's delicious. And so these pictures actually comes from Dad's Keto Kitchen. He does, there's ways to get ketogenic meals, for example, and these are 2 to 1 ratios. So I just wanted you to kind of see that she was eating well.
So one thing I can share from our experience with using ketogenic therapy in the treatment of mood disorders with younger children is that
Mhm.
the younger they are, it seems as though they actually need lower macro ratios in order to achieve high levels of ketones. So
Oh,
yeah,
so
we
not the
start,
4 to 1 ratio of the
no, we start
epilepsy
them at
world.
1 to 1
Ah,
and
excellent.
then move them up from there as needed. But those Brussels sprouts did look delicious.
Yes, yes. There was no complaints there. So her food sources, so her proteins included beef, chicken, salmon, shrimp, eggs, and dairy. Her main fats were butter, avocado oil, mayonnaise was very important, dressed up into different sauces, and dairy fats like heavy cream. She had, low carb vegetables for options, and her mom, bless her, made with lots of kids in the house too, made lots of ketogenic desserts to help her adjustment and to help her with compliance. And I met with her for just 30-minute sessions twice a week. I find clinically that when someone is moving from a standard American diet into a ketogenic diet, having those couple of touch points a week can actually be very helpful, even if it is just a shorter session. After 12 weeks, we moved to every 2 weeks. And then finally, we did monthly for about 6 months. And the whole time we tracked blood glucose and beta hydroxybutyrate blood levels with a Keto Mojo. And for this individual, she made ketones quite well. Her highest recorded ketone level is 3.5 millimole. We tracked her weekly averages over a 10-week span. And well, clinically, I'm also trained in functional nutrition, so I'm a little bit more interested in supplementation. But I had her on some stuff, so I had her on some methylated Bs and some trace minerals and some D and K2 and I just want you to know, though, that not everybody does these fancy supplements on a ketogenic diet clinically. There are beautiful, stunning published case studies for schizophrenia in which they didn't even add a multivitamin supplement. Someone just went on a ketogenic diet to lose weight at a weight loss clinic and put their psychosis, their lifelong psychosis into remission. So please do not get hung up on the supplementation that I use. And so for this person also, we added acetyl L-carnitine, and I can talk more about why we would do that. And so this wonderful girl, this wonderful young woman, she got really rapid symptom resolution. She said, about 2 weeks in, she's like, I think my hallucinations are going away. And you see this with them. They'll be like, I'm not sure, but I kind of think this is getting better. And you'll see them wait until they feel really sure because they're really afraid to get their hopes up. But working with this population, I was not surprised and did not, force them to address that, or think that or have to say that they thought that this was getting better. But at 6 weeks, there was absolutely no question to her or her parents or her siblings or her friends at her homeschool co-op. She had just a complete resolution of suicidal ideation, depression, anxiety, and hallucinations. And this was seen and corroborated by her parents and her treatment team, including her
Nicole,
therapist.
is this sort of timeline typical? I mean, 6 weeks, that seems remarkably quick to see that level of change. I mean, with medications, we're usually looking at the 6 week mark to see if there's really any change at all. But to be able to report these kinds of improvements at that point seems impressive. Is that common?
It is common. It is common. It's not everybody, and we can talk about that in the Q&A, like what does a non-responder look like? Are there non-responders? What is the level of improvement that we can expect or not expect? Like we can talk about that in Q&A a little bit more because I think that that's important. Not everybody is going to have a spectacular 6 week, but by golly, we see it often. We really do see it often. And so, yes, it is not unusual in this population. And what I do clinically is I have baseline assessments. So I'm not a psychiatrist. I'm a master's level mental health clinician, and so I don't have access to the PANS in order to assess psychosis or anything like that. But there is a significant mood component to schizoaffective disorder, and so I did some assessments. I looked at the GAD-7, the DAS-42, and a PTSD symptom scale, a PCL-5, that in and of itself is not supposed to diagnose a disorder, but it's supposed to be used clinically as a part of a diagnosis protocol. And so what we found was that, she only showed moderate to moderately severe anxiety at baseline. And remember, I got her right out of the hospital. So she was really on a lot of medication. And, we often see that when people are on really a lot of medication, their mood assessments that are really, they were made by pharmaceutical companies really to just measure symptoms. Well, the whole point is to reduce symptoms alone without any consideration necessarily of other measures of psychiatric recovery. So I suspect that if she was not on that level of medication coming out when I got her baseline, that these scores might have been higher. But she had a normalized GAD-7 by the end. Her DOS 42. So the DOS, again, that is a assessment where we look at subscales and not total scale necessarily. But the stress subscale decreased from 15 to 2, anxiety improved from 17 to 9. And so improvements in those domains. And then also you can see the PCL5. So this is a PTSD symptom kind of checklist, as I said. And so the mood symptoms and the cognitive symptoms showed the most improvement with criterion E. And yeah, so she did not, I would say, did not meet criteria for those types of things, but that this particular assessment is really nice because it drills down into some of these more subtle symptoms that and can have a transdiagnostic type of effect in terms of seeing how someone is suffering, actually, what symptoms are going on. The second person was a 32-year-old female. And this person had been suffering for over 10 years with schizoaffective disorder. I think about this person, and this person was an absolute model patient. And I'm going to tell you how I know that. And I have absolute permission to say who this 32-year-old female is because this person has actually announced it and wants this to be known. So this is the case study of Lauren Kennedy West. Lauren Kennedy West is someone who was on YouTube and had a very popular YouTube channel called Living Well with Schizophrenia. And her audience actually watched her disease process, watched her struggling with symptoms, watched her being hospitalized. And so she had a very large following, and at some point decided that she wanted to try a ketogenic diet and see if that could help her. And she started a little video series within her YouTube channel around that with everybody watching. And somehow I got connected with her. She found me, and we started her on ketogenic metabolic therapy. She had severe psychiatric symptoms. Her quality of life was pretty low. She had a really hard time functioning. She could not keep a job. She could not stay in school. She's a mother of a young child and two stepchildren. And she was one of the people that I think of as highly functioning still with schizoaffective disorder, but her quality of life was not very good. And she had multiple suicide attempts. Prodromal phase started in high school and got worse and worse. So all kinds of medications and therapies. And when I say she was kind of the perfect patient, that's what she was doing, talking about living well with this chronic diagnosis, going to therapy, taking her medication on time, trying to do everything that she was told in order to feel better. That made her a good patient, that made her a compliant patient. And so, she had a psychiatrist, she had a therapist, and she had a primary care physician, and I was the other person on her treatment team.
Can I just point out what an amazing treatment model that is, to have all of those different people who are working together on a common goal with a shared understanding of where they are and where they need to go. Not everyone is able to get that. And what a wonderful model for us to aspire to.
Yes. And I will say, although she had a treatment team, this is going to blow everybody's minds. Although she had a treatment team, we weren't talking to each other. I worked with her to teach her how to self-advocate with the people on her treatment team that were completely naive about ketogenic metabolic therapy. So when she felt she needed a medication adjustment, we would have a conversation, and then she would take that to her psychiatrist and self-advocate. When she felt like she needed blood work, or I said, I need a carnitine panel, or I really need some blood work, she would go to her practitioner and self-advocate for that. She worked with her psychotherapist and let them know what she was doing and asked them to monitor her and help her with this lifestyle change. And they agreed to do that. But ultimately, at the end of this case study, her her psychotherapist was blown away and happy, and her psychiatrist was completely uninterested. And not curious was how Lauren described it. And so I want to point out that while that is the ideal, people do not need the ideal in order to pursue psychiatric recovery on ketogenic metabolic therapies.
That's
Yeah.
an excellent point. Thank you.
Yeah. So again, I stuck her on a multivitamin. That multivitamin had B complex and trace minerals, vitamin D, electrolytes, and we put her on acetylcarnitine. We gradually reduced her carbohydrates over just 2 weeks. She was raring to go. So, her schizoaffective disorder had a bipolar features, and so I was trying to actually reduce her carbohydrates slower. But when people decide they want to feel better, sometimes they will just go faster and do their own thing. She achieved ketosis at 3.3 millimoles and maintained levels of ketosis over 32 weeks that we tracked. Her ketones were generally between 1 and 4 millimoles throughout the intervention. And so why do I keep mentioning carnitine? Well, carnitine is an amino acid, and we do make a certain amount of carnitine ourselves by putting other amino acids together. But carnitine is actually very abundant in red meat. Carne means red in Latin. Now, when individuals are on ketogenic diets, even those in the epilepsy world on like a modified Atkins diet for epilepsy, they can become carnitine deficient or insufficient between 1 and 3 months. And so part of a blood work for someone on a ketogenic diet really needs to be carnitine. And so why would that be? What's the big deal about carnitine? Well, carnitine is a shuttle that's needed to get fatty acids that the person eats or burns off their body into the mitochondrial membrane so that they can make a ketone. If you're trying to fuel a brain on ketones, you can't do that with fatty acids. You have to have a ketone body that will do that. And so if I'm trying to get treatment effects by looking at therapeutic levels of ketone bodies, I have to make sure that there is carnitine on board in order to do that. And so Lauren's ketones dropped. And Lauren's also an athlete, right? So more energy. And so I sent her off with much difficulty in Canada trying to get her a carnitine panel, but she finally got one, and we found that she had low levels of carnitine. So then we began supplementing, and her ketone levels popped right on back up, and they do quite quickly. So by week 2, she had a significant reduction in psychotic symptoms, and she actually needed her antipsychotic medications reduced at the 2-week mark because she was over sedated. She came and she said, I feel like I do in the hospital where they give me really large amounts of medication and I can't get out of bed. So she went to her prescriber and got that adjusted. She continued to have improvements over weeks. She kept talking about how her capacity improved. Her capacity is improved. And if you watch her videos, you'll see her saying that constantly and apologizing for repeating herself, but she just really could not find a better word to describe what this intervention was doing for her. And she returned to normal activities, and her quality of life really improved. So for her, this is a little bit what her quantitative outcomes looked like over 52 weeks. So again, this is not like a boom, you're better. I'm going to publish this case study showing you're better, and we don't have any idea about whether these treatment effects continue. This is 52 weeks of data showing stability. That's a year, right? And so you can see that Anxiety was down by week 22, steady decline in depression, anxiety, and stress scales. Depressive symptoms were gone, resolved by week 13, just 3 months. And PTSD-related symptoms reduced and stabilized. Little bit of minor intrusion here and there in terms of some life stressors that came her way, but certainly nothing close to what she was dealing with, and not even that clinically significant. Very stable. So in case one, the 17-year-old was able to reduce and eliminate all medications except her fluoxetine. At the time I published this, she was working with her prescriber to titrate off slowly and carefully. And Lauren, the 32-year-old, she eliminated metformin. She had comorbid PCOS and got rid of metformin and actually completely titrated off of her medications. And she has been medication-free and stable for a very long time. I will say, and this is the nice thing about writing up a case study with someone who's so public, I will say that she actually got quite ill and she had a temporary relapse of symptoms and was very afraid and nervous. And we spoke, and her first gut instinct was, oh my gosh, this means I need medication again. And I said, well, you had a very bad virus and you haven't been monitoring your diet very carefully. Let's just kind of get you back on track with that. And, and it resolved. So there was some kind of neuroinflammation going on, or sometimes when people get sick, their blood glucose goes up because that's a substrate the immune system uses, and ketone levels go down. We see it in epilepsy. People get sick, their ketones drop, and they start to get seizures. And so that can resolve afterwards. But yeah, so she's been very stable symptom-wise, save for that one really bad illness that she had, and she's all back on track without any problem now. They had physical health improvements also. So it's not on this slide, but Lauren actually got a lot of lean muscle mass going on a ketogenic diet. She's an athlete. And so when she went on her ketogenic diet, she did weight training, and in her case study in the series, you'll see we talk about how she gained muscle mass. And for the teenager, she showed BMI improvements from 29 to 27.4 with healthy weight loss alongside her recovery. And what's really profound is that the quality of life transformation that is articulated by these individuals who recover from again, what is supposed to be a chronic lifelong illness like schizoaffective disorder, where we do not have cures, we only have treatments, and those treatments are about symptom control. The quality of life transformation that they experience is just really profound for them and also for the people around them. So think of it from a system standpoint. Her wellness and her improvement, I'm thinking of the 17-year-old. When I talked to them again, when I talked to her, she was talking about how her relationship with her siblings had improved. Now she takes them to the coffee shop with her and is actually driving them places and helping her parents with that. And she was working. She was holding a job again, and she started an Etsy shop, and things with the boyfriend were amazing and doing really well. And so there's really big impacts that a PHQ-9 and a DOS42 and a GAD7 is just not capturing with this population. That just puts it in a totally different class than where our bar is for treatment with medications. So key findings and implications. Always with case studies, even case series, you want to think about that this is not generalizable necessarily to the general public. That's what we talk about. at some point, someone, I'm thinking of Chris Palmer, Chris would say, how many case studies does it take before we start to wonder if it's generalizable to the public? When do we get to like state that, gosh, maybe this, how many case studies is it? But we don't do it that way. But the key findings and implications is that for some people, they can have rapid symptom resolution using KMT. They can have sustained recovery. So this case series talked about 24 weeks and 52 weeks. There can be comprehensive benefits, huge qualitative gains in quality of life, along with health markers and metabolic function. And these were treatment-resistant cases. These were cases where standard of care failed. These are cases where parents made sure that they did what they needed to do and they still were not well. This is the case of the perfect patient who did what they were told for 10 years and they still were not well. So this would suggest that maybe for some people, this might be very helpful. And so future research directions, because certainly we can't rest on our laurels with case studies and case series, is that we're going to want to study this with diverse patient populations, standardized protocols, and of course, RCTs and controlled studies that allow us to assess the generalizability and the long-term efficacy of this as a treatment modality for people with serious mental illness. So again, 2 successful cases with complete symptom remission. There's others in the research literature if you want to take a look. We had 6 weeks to resolution of psychotic symptoms, sometimes sooner. And the longest in this series was a year, 52 weeks of sustained long-term recovery maintained. And I think that is it.
Thank you so much for sharing all that detailed information. One of the things that we hear about a lot is sort of questions on the practical implementation of this. You talked about the perfect patient who follows all the instructions and was still struggling. What is it that you see are the most common barriers that your clients experience when they are trying to implement ketogenic metabolic therapy? Is it that their own habits need to change, or is it that they're getting resistance from people outside, like the psychiatrist who's not curious, or where do you see those biggest obstacles coming from?
So the biggest obstacles and the most requests that I get for assistance and help with is the psychiatrist. So they'll go to their psychiatrist and they'll say, I want to do a ketogenic diet for my mental illness. And some of the psychiatrists will just flat out say, no, you're going to give yourself a heart attack with all that saturated fat. Some of the psychiatrists say, go ahead and do a ketogenic diet because they're thinking a ketogenic diet is like a vegan diet or a vegetarian diet or a Mediterranean diet. And they don't really believe that it's going to have medication-like effects that they have to monitor or pay attention to in any way, which in fact is not the case. Ketogenic diets are powerful metabolic therapies. And I'm sure everybody knows, or people, your many trainings, I'm sure have talked about this, but it's used in seizure disorders and they bring it out when all other medications fail. It's that powerful of a treatment with medication-like effects. And so these people on, 4 to 7 medications, they'll add on a ketogenic diet and the prescriber will not assess their medications within that context. They won't think, oh, I've just added the most powerful anti-seizure medication in the form of a diet onto this person's medication protocol. Maybe there's some adjustments that might be needed. And so my people will have to learn to self-advocate as best they can with prescribers as they get better and they start to get side effects from their medications, not the ketogenic diet necessarily, and get those adjustments made. So it's really professionals that are in the way of these, sorry to say, it's professionals that are in the way of these people getting access to the help that they need on the ketogenic diet. So I am in I think a distinct advantage because the people who come to me are already seeking it out and are highly motivated. They're like, get out of the way, lady, tell me what to do. I want to try this to see if I can feel better. And they often come with a support person, or I encourage them to bring on a support person. One of the things that I see in this population, because in schizoaffective disorder and schizophrenia, there's such a variability in functioning. Sometimes I will get someone who's more high functioning and does not need a support person, but some people do. And sometimes with families, it's like they're like, well, they're adults and they need to do this diet, right? And and some of the conversations I have with them is you're adult with this severe mental illness doesn't actually function like an adult. Therefore, your expectation that they're going to be able to monitor their food and track their food and do meal prep and all the planning around that is not a reasonable expectation. So let's pretend you have a child with epilepsy. And what would that look like? And so there's just, it's just that sort of thing. But I think as professionals, we really have to keep in check this idea that there's these barriers, these barriers. We don't talk about medication and therapy like that. I mean, we might say, oh, there might be barriers to therapy around cost or getting there or feeling well enough to participate. But we don't say, oh, these barriers. That's not what my people are talking. That's not what they're experiencing. Um, there's, yeah, there's different pieces. So many, because I have a nonprofit and I bring people into an online program providing education and support. I have many people who are low income or on government disability who are on very tight budgets or receiving, food stamps or assistance. And they manage to do it. And it's not just my population. Like there's a doctor who works with people in the Bronx, very poor communities, helping them with diabetes using ketogenic diets, and they also are successful. There's actually some stuff I think published about that. So this idea that there's these barriers and that somehow this is not doable, I think has much more to do with professionals' own countertransference and biases around diet and food. I do professional trainings for psychotherapists, and one of them is ethics specifically, and we kind of talk about making those biases aware. So if you can't imagine your life without carbohydrates, you're going to bring that into the treatment room, or you're going to assume that that person can't manage without carbohydrates. Or if you have a hard time taking up space and saying something like, oh no, family, I do not want to go to that restaurant because there's nothing there for me to eat, even though I know it's your favorite restaurant. If that would make you super uncomfortable and you can't take up space to take care of yourself, then listening to a client talk about needing to do that, that will be a barrier, you'll think, when really it's not a barrier. It's about your stuff. So, yeah, I don't know. Did that answer your question?
It did, and it's so interesting to hear you talk about that because it's so similar to what we experience more generally when we are talking about mental illness in childhood. That there are the barriers most often are actually the professionals who
Mm-hmm.
have a preconceived idea about what mental illness is and what it looks like in adults and sort of can't imagine that being applied to children. And it becomes sort of a process of clearing the path for the families to be able to access the treatment that we know works. And this is very much what we've seen not only with ketogenic therapy, but with other types of interventions as well in childhood. Um, you were talking about families that maybe didn't have a lot of money to spend on food. That this is a common question people have. Well, isn't ketogenic therapy expensive? You have to eat. You have to eat steak in order to be on ketogenic therapy. But we know that that's not true, that it can actually be quite affordable depending upon the way it's implemented.
Mhm.
But there are other experiences that people have, backgrounds, cultural foods, cultural expectations around food. Have you seen with your own clients that there is a process that people have to go through in order to allow it to adapt to their personal cultural needs?
Yeah, so when I do get asked that question sometimes, and it's not just cultural, it's also like age and, there, so like, is there a woman in the house that's going to be expected to do all the cooking and meal planning, right? So it's like, it's a big deal. So yeah, the piece, the case that comes to mind whenever anybody asks me that question is of someone from an indigenous population whose sense of identity was very much, as all of ours is, connected to food and fry bread and, ideas about what cultural food was for him and for his family. And he was having a really hard time because I can't have the fry bread during the celebrations. And I, this is my indigenous food. I should be able to have access to this. And then I had a conversation with him about, okay, well, going pretty far back, yeah, that was your cultural food. What was it pre-colonization? And what would that mean to go back to an identity and a definition of what your cultural food is farther back in your history? What would that mean for you? And so it meant hunting, it meant very seasonal things. And this person actually ended up having a very strong and proud sense that he was actually going further back into his indigenous heritage by doing this way of eating. Some cultures are more difficult around that. So Asian culture with rice, for example, um, they can have a little bit more difficulty, but again, it can be successfully accomplished. And so I really think that there is a great amount of wisdom that metabolic psychiatry is going to someday extract out of the epilepsy world, because there are literally hundreds of dietitians all over the world that use ketogenic metabolic therapy in epilepsy centers, and they have different cultures, right? And so I would just love for someone to pull all that wonderful information together, or maybe we get to use epilepsy centers, for this purpose. But yes, it's doable. It's just, like any narrative piece, you have to make it make sense for you.
One of the things that we see over and over again in terms of treatment for mental illness in pediatric populations is that practitioners often have sort of a bias around what the diagnosis is. And the child will come in with a certain set of symptoms, and it's always ADHD, or it's always ADHD and anxiety. And there isn't a lot of individualization around the treatment plan. How do providers avoid that sort of one size fits all, like everything sort of has to be the same approach when you're implementing KMT?
So with KMT, ketogenic metabolic therapy, I am thinking about the health of the brain much more than whatever the particular diagnosis is. So, and the reason I do that is because in the epilepsy world, when people do ketogenic metabolic therapy, after 1 to 5 years, there's a really good chance that they can come off the diet. Some people just go right on back onto pizza and hamburgers and standard American diet, and they don't have seizures, which would suggest that the brain is healed. And some people have to stay on some form of a ketogenic diet, meaning that it's low enough carbohydrates that there are at least periods of ketosis that occur, and they're able to stay seizure free from that. And in the research literature, there is a really important conversation going on about ketogenic metabolic therapy being a trans diagnostic intervention, because we are seeing case studies and improvements in things like PTSD, autism, Alzheimer's disease. We're seeing it for schizophrenia, schizoaffective disorder, bipolar disorder. And so there's a transdiagnostic component. And so while I will always listen to someone talk about what they feel like their diagnosis is, that helps me kind of understand what their experience is as a human being with their symptoms. I'm really not as interested in the diagnosis as many people are. And I know that's very different than many clinicians. I'm really just focused on healing a brain with KMT and then helping them integrate their new sense of self into their recovery identity.
Can you talk a little bit more about this transdiagnostic approach? Because it is very much different from what we're all taught when we're in graduate school, right? We're taught to use the DSM to segment people into one diagnosis or another, and we treat that diagnosis based on the formularies that have been developed for what medications you use for ADHD versus what medications you use for anxiety. And as you're talking, I'm thinking about the degree to which ketogenic therapy sort of blows up that model, right? And
Yeah.
and so if you could talk a little bit more about that, I'd like to hear your thoughts on it.
Yes. Well, I mean, you have a highly educated group attending, and they already knew that model was blown up. There's been criticisms about the DSM for decades now about it. Is it actually useful? Is it actually accurate? What is it based upon? Um, and and so it was already a dead model that we were just dragging around with us, would be my opinion about that.
I
And
share that
so
opinion, so thank you.
yeah, I mean, so how lovely we now have a trans diagnostic treatment where we can just finally kind of put that away, because it's not particularly helpful. I didn't find it helpful as a psychotherapist, other than it helped me, like, oh, this is CBTI for insomnia, or this is CBTP for psychosis, or this is the CBT I pull out and I kind of focus on these particular types of thinking, the cognitive distortions, right? I mean, like that's really and that can still be useful. You know, people with OCD have a different flavor of cognitive distortion sometimes than someone with generalized anxiety, and that can help us as clinicians to kind of zero in on where we want to restructure thoughts. But I don't think the medication model, where this is good for this and this is good for that and so on and so forth, is really that clean, because quite frankly, we just throw the kitchen sink at them now.
We do, and we are constrained by the insurance models that say, well, no, with this diagnosis requires this medication. I can't even tell you how many psychiatrists that I've talked to over the years about children will say to me, well, I'm not allowed to prescribe that medication, whatever it may be. And when I say why, and they say, well, the system that I work in has a formulary. And
Yeah,
because this diagnosis has been given, these are the only medications that I can possibly use. Uh, that doesn't, to me, seem to speak to the needs of the individual patient who's sitting in front of you,
right.
whereas ketogenic therapy does, because we can adapt the food plan to match that person's personal tastes, personal preferences,
Oh yeah.
the textures that they like, their cultural foods that they've grown up with. All of those things can be maintained. And I really liked how you talked about the idea of sort of integrating it into this new sense of who they are. Food is so much a part of our sense of identity, personally, familially, culturally, that being able to maintain that and not sort of be stuffed like a round peg into a square hole, it really becomes an individualized approach to treatment.
It absolutely does. Yeah.
We have someone who's asking whether or not you could share information about anybody who did have the obsessive compulsive disorder diagnosis and how ketogenic therapy impacted their symptoms and treatment.
Oh, yeah, absolutely. So I actually have a published case study um, of a gentleman. I did not manage their ketogenic diet. They managed their own ketogenic diet. So it was a retrospective case study that I reported on that happened after the fact, of course. And this person had OCD, and they went on a ketogenic diet. And about that same time, they decided they were going to go do ERP, exposure response prevention therapy. And they were already kind of, it takes a little while to get into the therapist, and it takes a while to have that initial consult and to do the prep work to actually do exposure therapy. So he was well into his ketogenic diet and was actually feeling improvements, significant improvements. And he told his therapist that he was doing a ketogenic diet, and she said, "Don't do that. That's going to make your mental health worse." But he didn't listen to her because he was already having these great experiences, feeling better. And so what he said was that he did not think he would have ever been able to do ERP if he was not on the ketogenic diet. He said that it made it so much easier. He felt like the ERP sessions were so much more productive. He actually, um, it took him about 6 weeks, he said, before he felt a complete remission of OCD. And he's been in remission. He was in remission for quite a while when I reported on him. So that's one case study. There's also two other published case studies. I cannot remember I think it's McDonald and Palmer, um, where there's two other case studies where they do a ketogenic diet for OCD, go in remission, went off the diet, would get symptoms back, go back on to the ketogenic diet. And so that should be very interesting to clinicians that they can actually just get symptoms back when they go off the diet. So I see lots of great remissions of OCD. But we should talk about, like, because there is that, does this work for everyone? Kind of, what does this look like? And I will say that I do not think I have encountered too many individuals who have done the ketogenic diet, and I know they're doing it properly, and I'm monitoring it, and that do not get some benefit. Now, what is the spectrum of that? It's the one end is that spectacular 17-year-old who, went off to college, or the other person in the case study, all the way to, I have someone who their mom, it's an adult, but their mom's managing their diet. I know she's doing it properly. And before the ketogenic diet, this person was just wreathing on the couch with akathisia and constantly being hospitalized. And the mom was like, "I was really hoping for a miracle. I was hoping for this remission, but she still has these thoughts. She still wants, she'll still run off to the convenience store and try to, get goodies." Like, there's, and I said, "So there wasn't a remission, but what's better?" "Well, she's not wreathing on the couch with akathisia. She's not in the hospital every month. You can go on a trip now, right? You guys can actually leave the house and have her be an adult and be able to take care of herself now, where that was not an option before." And so, and she's knitting, she's doing some kind of craft every day, and she's not crying constantly anymore. And so while the mom was like, "Yeah, but yeah, I know, but there's still improvement. This has increased a quality of life for you and your family that was not possible before." Um, so
Yeah,
that's
you're
the ring. Yeah.
yeah, you're really talking about a harm reduction model, right?
Yeah.
That families often go into this, as you said, sort of desperate for the miracle. Like, we jokingly refer to our community as the no stone unturned club.
Yeah.
These are families who are trying absolutely everything they can get their hands on to improve their child's quality of life, reduce their symptoms, intensity, frequency, improve things for the whole family. And ketogenic therapy is that should, for a lot of people, it's that next thing. Like, this is going to be the thing that is going to make everything go away. Is going to fix my child. Um, and that is not necessarily the best way to be approaching it, because we can look at it from the standpoint of where are we starting from and where are we ending at. Is there an improvement? Does it mean that we no longer have this diagnosis? Does it mean that we never have to take medication again? Does it mean we're never going to have any symptoms? Well, not necessarily. But as you said, where were you before and where are you now? And if that has improved, isn't a nutritional option one worth exploring?
Absolutely. Yeah.
So I have another question here, which is on what is your experience around the medication? You presented a case where one person, their medications reduced, and with one person, they stopped taking them altogether. Generally speaking, in your experience, what is the sort of typical outcome when it comes to medications after or during ketogenic therapy?
So it is not unusual for individuals to be able to discontinue medication after ketogenic therapy. And this should not surprise us because, like I said, ketogenic therapy has medication-like effects. And also, ketogenic therapies might heal brains and such, right? So this should not be mind-blowing to us, although it often is. And I would say that the biggest the biggest thing I see, again, professionals, other professionals, is that many prescribers feel like they are very good at tapering and that they understand how to taper medications. And unless a prescriber is using hyperbolic tapering methods with this population, I do not think that is the case. I think that prescribers adjusting medications down, not using hyperbolic training, I will say that is becoming standard in Britain and Australia. They are whipping out the Maudsley's deprescribing guidelines and following them carefully. But not here in the US and not here in Canada. And I've had several instances where someone has been truly recovered and has been on the track of reducing medications, has gone to their prescriber and gotten a too big of a reduction, and they have had rebound psychosis. And then the prescriber says, look, see, you need medication. Now, how do I know that wasn't the case? That wasn't the case because when they put that person back up and they stabilized him on that medication, there's been more than one, not just a him. When they stabilized them and then they properly titrated themselves down with another prescriber hyperbolically, they did not get a rebound psychosis and they stayed stable and they got to keep their recovery.
This is something that we feel very strongly about here because we see it with children all the time. They are routinely put on antipsychotic medications, and then when the time comes to come off those medications, they're given a weaning schedule that is absurdly fast. And they are not necessarily given any education around the fact that when weaning off an antipsychotic, the withdrawal symptoms mimic the psychotic symptoms that the medication was prescribed to address in the first place. And
Right.
so if that weaning process happens too quickly, what happens is they have these withdrawal effects. It appears as though the psychosis is returning, and they then, the doctor recommends returning to the previous dose. For those who maybe don't know what hyperbolic tapering is, can you describe it and sort of summarize it?
Yeah, so when you generally talk to a prescriber about reducing medications, they will tell you to go in particular grams, go down this many grams. Hyperbolic tapering, you go down in percentages, which is really kind of hard to I remember when I was first learning about it and people would say that and I was like, I don't quite understand what that means, although math is not my strong suit, right? So if someone is on 50 milligrams, a non-hyperbolic taper might be taking them down 25 or 10, right? But if you're going down percentages and you're going down in a hyperbolic manner, you might go down a max of 5%, and that would be 2.5 milligrams. But Nicole, you say medications don't come in 2.5 milligrams. What do I do? And that like unfolds the whole like it's a whole skill set to learn how to hyperbolic taper when pharmaceutical companies refuse to make medications and dosages that would let someone hyperbolically taper. And so people learn these different skills. There's free hyperbolic tapering courses for the general public. There's hyperbolic communities. They're very well, lots of good ones, lots of good support out there for that journey. It can take years to get off these medications. And so I always tell people there's two parts to psychiatric recovery on ketogenic diets. First is the mastery of the diet, and the second is learning for yourself, self-educating on hyperbolic tapering. Because you must go into your conversations with your prescribers educated. Otherwise, you will not know if they are going to suggest something that could cause a rebound psychosis and put your whole beautiful recovery at risk.
There are several psychiatrists with whom we work who, when they are tapering using the compound pharmacy, so that they are having their medications compounded. So instead of just being instructed to cut it in half, which is this 50% reduction, but then when you cut the second one, when you cut that one half into a half, it's a larger percentage of the total dose that's being taken away. And that people don't realize that because they aren't doing the arithmetic to realize like, oh my goodness, I'm losing a greater percentage of the total dose by the instructions that I'm being given. And so that is important. I have read some things that have indicated that, and heard some things from adults who do this, that there are times in the adoption phases of ketogenic therapy where there are sort of moments of milestones, I should say, the 6-week mark, the 4-month mark. What are the milestones that you've identified in your work with people in terms of when folks start to see some kind of change?
Yeah. Well, I will say that sometimes I get people where it's not till there's a medication adjustment down that they're able to feel the effects. So bear that in mind too. There's a story that Beth Supek-Kania, who is a epilepsy dietitian for over 30 years, says and talks about in her training. I think we have time. I can whip that out because it's really important. So she talks about how she was an epilepsy dietitian, and there was a child with epilepsy, and she had really severe seizures, like so severe she was going to die, just nonstop seizures, and she was on every medication to the moon and back, and a ketogenic diet, a well-formulated ketogenic diet for that purpose. And she just was not getting seizure control. And Beth took the neurologist aside and said, why don't we try reducing her medication to see if the ketogenic therapy can do its work? And he's like, I can't possibly justify that because she's still having seizures, right? They'll come after me because I'm taking her medication down. And Beth worked with them, and she's like, well, she's not going to make it. She's not going to make it otherwise. So what do you got to lose, right? So they went ahead and they reduced her medication, and her seizures stopped. Her ketogenic therapy was able to do what it came to the forefront to do, what it was supposed to do. And I see that in psychiatric world. I do. I see people that are like, I don't feel like I really feel good on my ketogenic diet, or this is not working. And I'm like, see if you can get like a 5% reduction, just like, just a little bit, and let's see what happens. And often they're like, oh, I feel a lot better. I'm starting to feel better. Like these people, they're coming on this ketogenic therapy with 7 medications, and there's lots of beautiful recoveries with people on medications as usual. I don't want people to think they have to get off their medication. Please do not go off your medication to feel your ketogenic effect. But just understand that if it's been 7 months and you have been consistent and you've had a Nicole or an Elizabeth watching your diet and making sure that it's on track and you know you're doing it right and you still haven't felt effects, consider that. Consider, like, is there something trying to work on the same pathway that my ketogenic diet is trying to work on? Psychiatric medications impair metabolism. Ketogenic diets improve them. It is not crazy talk to think, oh, maybe there's some problems going on here with that. So some people feel amazing and are recovered in 2 weeks and absolutely know something good is going on under the hood. Some people, it's about 6 weeks. Different, like OCD, sometimes it's 6 weeks. I've had treatment-resistant depression where it's been 7 months and they just kind of woke up one morning and was like, yeah, this is gone. And they did not just there's some healing threshold, I think, that happens for people sometimes. So that's kind of an impossible question, but I always say, so often many of the people I work with, they're already on low carb and ketogenic diets trying to feel better. Probably 80% of the people I work with come to me like that, and they're not getting treatment effects. And then you have to work with them and help them do it properly. And then they start to feel good. And I say, your start date is with me. Yes, I understand you've been doing a ketogenic diet for a year or 6 months with no effect. So 1 month into our work together, you can't say I've been doing this ketogenic diet for 7 months and I'm not getting better. Oh no, we start over 1 month when we began getting your macros right.
So that's very interesting, and I'd love to hear you talk more about, a lot of people think that ketogenic therapy is a low carb diet, and it's not. Can you highlight the difference between ketogenic therapy and a low carb diet?
Yes, I think so. So so there's different kinds of ketogenic diets. So when we talk about ketogenic diets, we generally think, okay, the carbohydrate reduction is such, well, gosh, there's so many, So, okay, so there's ketogenic diets generally assume that ketones are either being made or added in. There's something called an MCT oil diet, right? Carbohydrates are not reduced enough for a full metabolic switch over into ketogenic fuel. So then we throw on a bunch of exogenous ketones in the form of MCT oil. Low carb diets that do not moderate protein per meal will have individuals in states of ketosis periodically, but not consistently. And for some people with sensitive brains, that period of time that their ketone production has dropped because there's been a large amount of protein in a meal, because it's not just about carbohydrate restriction, that can cause downstream effects later in terms of symptoms. Just like someone with epilepsy, if their ketone production drops too low or stops, they can get a seizure. Someone with mental illness who needs a truly medical ketogenic diet or a modified ketogenic diet, they can't be out of ketosis, although some can. So, and some people don't have a lot of body fat stores to unlock, or it's early on in their ketogenic diet and they're having trouble unlocking that for fatty acid fuel that can be turned into ketones. And so, if that's the case, they have to eat their fat in order to get therapeutic levels of ketosis. So a ketogenic diet for this purpose is a very exact thing. And if you are doing it for a psychiatric treatment, you want to understand your macros, you want to understand your per meal macros. We would never close our eyes and reach into a medication. I always do this, cracks people up. Like, you wouldn't just close your eyes and reach into some bottles trying to figure out the dosage. You wouldn't do that with your ketogenic diet. You would know your ratios, you would know you have the right amount of fat, the right amount of protein, and the right amount of carbs each meal. And so yeah, low carb might not be sufficient for many people, although there are published case studies, right? They went to the weight loss clinic and that's all they needed to do, and they went into remission from lifelong. So not everybody needs the fancy KMT, But my goodness, if it's something that's important and you don't want to spin your wheels for 6 months trying to do it yourself, just go work with somebody.
So, in the last few minutes that we have, I would love if you could sort of give a little bit of an overview of your brain fog recovery source program. Nicole works with adults, very complementary work to what we do with children and families. Our next research study is going to be on children ages 6 to 20. And I want to hear what it is that you're doing with adults, and so that if there are adults in our audience who are interested in participating, they can.
Oh, absolutely. So I have my practice, and in my practice, I have an online program. And this online program has 2 live Q&As with me a week, and I do macros, and I teach people all the things I do in private consultation, basically in a group format. And I think the group format is actually quite superior because there's that peer component. They get to see each other in the Q&As, and they have a community that they're doing this with. But my nonprofit allows them to enter that online program at reduced or no cost. So either low income, partial scholarships, or full scholarships for those on government disability. And so it's just very, very rewarding work. Yeah, it's really rewarding, because they don't necessarily, it's not standard of care. So even if someone's on government disability and has state insurance, it's not standard of care. Even if they found a doctor that takes that insurance, that state insurance, for example, they may not have access to it. And they can't go to a private consultation. Even an inexpensive diet coach, right, that has this training is out of reach for them. Or there's the thing where they'll only do a few sessions when really they deserve and need consistent support in order to be successful. So my nonprofit does education and support. And again, I don't talk to their prescribers. I teach them to self-advocate, and we go from there.
So, Nicole, can you give folks an idea of what it is that you do in that program with them? I'm going to throw into the chat a link to the CMHRC program that is a research study for children, as I mentioned. And I've already put into the Q&A a link to your website and to your program so that people can access that if they would like to as well. But what can people expect out of your program?
Well, they would get access to the lessons. So there's no time limits on my program because I have so many people on with so many cognitive issues that I find that a time constraint is just adds a lot of stress. I also have they get to enroll a support person free of charge that gets all the bells and whistles that they get. So if their support person decides they want to do a ketogenic diet with them, I help them do that. But they work through the lessons one by one. I transition them down to a medical ketogenic diet over 4 weeks. I have them begin learning to track. I get a baseline of their carbohydrate consumption, and then they start lowering that systematically over those 4 weeks. And then they schedule a one-on-one macro session with me so that I can focus in on them and making their macros. And then there's also a nutritional component. So like I said, I practice functional nutrition. So I'm very interested in that. And we actually do this really cool nutrigenomics thing where they get their genetic data and we run it through a reporting software to see if they might benefit from specialized types and forms. And for those that don't want to do that, it's still a really excellent education about nutrition for brain health in there. And then the third phase of the program is all the other metabolic psychiatry components that you add to a ketogenic diet or that you can add that really supercharge it, like exercise, meal timing, light exposure, sleep hygiene, avoiding metabolic disruptors in our environment, in modern society. And then, additionally, maybe adding supplements or different things. We talk about going to get CBT, how therapy can be so much more productive after you've been on a ketogenic diet and your brain is just working a little bit better. So we steer them back to that if they would find that helpful. And then there's also a private Facebook group community where people ask questions and visit with each other between live Q&A sessions.
It sounds like you are putting together the guidance, the resources, and the support for a community that we value so highly. I'm so glad that you're doing this for adults, and we're excited to be doing it for children. I also want to highlight, Nicole, that you have two fantastic coloring books that are
I
not
do.
just for children. Oh, this is reversed, but it's the Happy Brain Coloring Book, and it says Ketogenic and Metabolic Therapies for Mental Health Recovery. And we have the little mitochondria and the brain, and they are just doing all sorts of fabulous stuff, taking their supplements and going to the gym and doing their exercise. And we have your second one, which I just got in the mail. Thank you, Nicole.
You're
Happy Brain
welcome.
Coloring Book, Ketogenic Nutrition for a Healthy Recovery. And this one takes our little brain through the foods, the avocados and the onions and the meats and the turkey and all of the sausage and dairy and all of the wonderful things that you get to eat on a balanced ketogenic diet.
Mhm. Yeah, absolutely. There's also an affirmations one coming that I'm working on, healing
Yay!
affirmations for metabolic therapy. So that's going to be fun when that gets done.
So as an adult who likes to color, it's very soothing. I can say these are not just for kids, and they really are just beautifully done. So thank you
Thank
for that.
you.
And as I said, I put Nicole's contact, or not contact information, but her website, and the information on how you can reach her if you would like to, into the Q&A, in the answered questions. So you can see them there. And I want to say thank you to everyone who attended today. We appreciate the time that you took to come and learn with us. And we appreciate the fact that you are interested in ketogenic metabolic therapy. We are here to provide these supports and services so that we can support the overall goal of getting as many people as healthy as they can possibly be. So thank you for being here with us. I'll just put out a couple of reminders that next month in February on the 18th, we will be having our webinar. The topic is mental health for everyone, mental illness for some, where we're looking at the difference between mental health and mental illness, and helping our audience understand the differences and how to identify one versus the other, and when you need to seek out some professional support. In February, we will also be having our monthly clinical seminar on February 25th, which is called The Myth of Misbehavior. This is where we break down and dispel the myth that children misbehave, and instead look at what needs are being communicated by behaviors and symptoms that adults maybe don't find to be very desirable. But we're going to look at it from the child's perspective, differentiate behaviors from symptoms, and talk about what is being communicated by children. And so that is all coming up next month, as well as our monthly book club, which will meet on the 19th of February, where we will be discussing The Bipolar Child by Dr. Dimitri Popoulos. So thank you again, Nicole, for being here. As always, it was a pleasure talking with you, and I look forward to seeing you again soon and seeing our audience at our next event. Thank you, everyone. Have a wonderful evening. Good
Thank
night.
you.